we have people who are really obese having type 2 diabetes, but sometimes they can need insulin and they can have some complication like the ketosis, which is very, very rare in the type 2 diabetes. This is the form. And I work on this more. I try to look what can be the link between this form of diabetes and some affections that are very common in Africa. I look the link between this type of diabetes and the HHV8, the human herpes virus type 8, if we could find a link between these two pathologies. And I found more affections of this in the group of people having diabetes, this form of diabetes. I found many a high prevalence of these infections in this population.
Doctor, is it Cikomola? I don't know how you say that. I'm just guessing on that. Maybe you can correct me if I'm wrong.
Yes, we say Cikomola.
Cikomola. Okay.
Yes.
Well, I've never come across that name before. But you're in the Congo, is that correct? You're in the Democratic Republic of Congo.
Yes, yes. I'm living in Congo in the eastern party, in Bukavu.
Well, it's a pleasure. You are our first member from the Congo. We had someone from Botswana in here the other day, but first one from the Congo. Well, if you don't mind, well, first of all, thank you for doing this. I know this is probably in the evening time for you, but thank you for being here. Would you be so kind as to give us a little bit of your background for the people that probably most people here probably have not met you before. So can you share with us your background?
Yes, thank you very much for having me to this meeting. I'm a medical doctor that I did my study here in Congo, my general medicine, and then I moved to Brussels for my specialization. I did my specialization in endocrinology, and after this, I started PhD in diabetes, and I work more on the African form of diabetes, and then I moved back in Congo. So now I'm working as a clinician in an hospital, and I'm also I'm teaching at a university, and I'm in charge of the course of endocrinology, diabetes, and nutrition. Yes, that I think I can say about myself.
Okay, so endocrinology, and you specialized in diabetes, and you mentioned African diabetes, and many people don't know diabetes has a number of different subcategories. We hear things like Jamaican diabetes, and there's LATA, and there's type 1 and type 2, and all these different varieties. But can you explain to me a little bit more? How does the African version of the diabetes sort of maybe differ from what we might see here in the United States, perhaps?
Yes, so we do have, of course, the type 1 and type 2. However, there is another type of diabetes like that can sometimes look like a type 1 and sometimes like a type 2. So these people can have some acute complication like ketosis diabetes. And for the first time, this form of diabetes have been observed in USA, I mean, in Black people. And then we used to see this kind of diabetes. We have people who are really obese having type 2 diabetes, but sometimes they can need insulin and they can have some complication like the ketosis, which is very, very rare in the type 2 diabetes. This is the form. And I work on this more. I try to look what can be the link between this form of diabetes and some affections that are very common in Africa. I look the link between this type of diabetes and the HHV8, the human herpes virus type 8, if we could find a link between these two pathologies. And I found more affections of this in the group of people having diabetes, this form of diabetes, I find many a high prevalence of this infection in this population.
What is in I guess, and I'm sure it's different in different parts of Africa, but let's say in the Congo where you're at, what is the relative incidence of diabetes? In the United States, I think we're quoted about 9-10% of our population is diagnosed with diabetes. What do we see in Africa, or at least in the Congo?
Yeah, we do have the type 1, yes. The type 2, we have many people. If I compare what we see in the last time, we are looking more and more type 2 diabetes. Now we have a prevalence about around 5% of the general population. Uh, Most of them, they are obese. They are living town cities, and they have adopted a new way of eating. They try to to adapt it a way of living as what we are looking in Europe and in USA. So talking about insulin, we some study that we conducted here, we found, of course, insulin resistance among these people having diabetes. So I may say that there is no really a big difference between what I'm observing as type 2 diabetes here in Congo and what I saw in Belgium.
You did your medical training initially in the Congo. How does, I mean, is there sort of in the United States, nutrition is not very much emphasized in the medical training. The nutrition that is taught is very much, 60% carbohydrates, a whole grain diet, and fruits and vegetables, meat is bad for you. Is that the same message that they're talking about in the Congo? I mean, obviously in Africa, hunting and meat eating has been a way of life for, as long as Africa's been around, is my assumption. So do we have a big sort of nutritional bias in the Congo?
Yes, we do. However, most of time we used to focus more on malnutrition, not obese, but for those who cannot accede to food as they want. And when we have been training for diabetes, we do. I couldn't found any time receiving some advices from my supervisor talking about nutrition, how people suffering from diabetes have to take to eat. Most of the time, we focus more on medication. They have diabetes, we have to give them medication, and no time to discuss with them about food, what they have to avoid, what they have to eat. This is, I think, we have to work more on this and change this way of working.
And my understanding is, in your practice as an endocrinologist who obviously sees a lot of diabetes and other, I'm sure, endocrine disorders, you are utilizing nutrition, I think low carb nutrition. Is that fair to say?
Yes, yes. And as I was saying, I studied in Belgium, and I used to focus more on medication. But what I realized that it is this way of working doesn't work. It's, I don't know, because every time people are coming back with taking exactly what I said, taking the medication is exactly what as I suggested. But I used to add a new one, and I have last 2 years ago. I met someone from UK, Dr. Kavan, and I read his book talking about the diabetes remission. And since that time, I tried to discuss with my patient about how to bring down carbohydrates in their diets. And it's really amazing what I observed, because as soon as they started cutting sugar from the diet, I could observe a good control of the disease. And I use them. Sometimes I started to 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 stop some medicine just by trying to change the way of eating. That's why I was very happy, and now I'm starting trying to teach people some next month. I'm giving a conference about this in Congo, trying to bring people to understand more the importance of working on dates more than giving medicine.
And I, certainly applaud you for that. That's something that I think we lack in medicine. We have a tremendous reliance on the pharmaceutical industry to sort of basically provide symptom management. How are you? How are you being received with your patients? As far as nutrition for, if you get a diabetic and you sort of point them towards maybe a low carb approach. How successful are you with that?
Yes. First, as you may know, this is not the international recommendation, and even the national recommendation. So when I'm trying to explain these, people usually show me the national recommendations and the national and international recommendations. So at the beginning, it's really not easy to let them accept this way of working. But when they tried, they realized that this is the good way of 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 the really good way to try to control the disease. And more than this, when I'm talking about this, I think we do not have many restrictions as they have been done for the last recommendation. Not eat meat, not to eat meat, not to eat many things. But now I'm telling them they can eat meat. They can even try cheese and many other things that they couldn't take anymore.
What is it? So, and again, having never been to the Congo, I've been to several African countries, but I've not been to the Congo. What is the diet of the typical, Congo? How do you even say the part? What is a Congo person even called?
Yes. I don't know
Congo,
which country have you already visited in Africa. Maybe I can make some comparison.
Yeah, so I've been to Tanzania and Kenya, and then down to
Yes.
South Africa. So,
Yes. So in Kenya, for example, we have what we call ugali. Um, in French, we do call it fufu. So this is the same we used to find in Congo as well. It is a kind of bread from Inyan, for example. Uh, so people used to take this early morning at for the dinner as well as so every time they are taking something which is very very rich in carbohydrates. Yeah.
yeah, and so previously, and there's been a few studies looking at adding animal-based nutrition because you'd mentioned that previously malnutrition and food insecurity was a big problem in Africa. We always see the difficulties with a lot of people with starvation, and they saw that adding animal source foods, whether it's eggs or dairy or perhaps even meat, has a tremendous benefit in that particular population. There was a study, I think, I don't know if it was in Uganda or Kenya I think it was Kenya looking at school children, and by adding, animal-based nutrition, it improved their academic performance significantly. Um, is Congo a place where there's still a lot of food insecurity and malnutrition and starvation, or no?
Yes, yes. So we do have the two problems. We have the starvation. Yes, many people, and now I have to say that last year with some colleagues we work on what can be the future for these people who have been suffering from malnutrition, and we observe that when they are changing the way of eating. From most of them, they are developing diabetes. So we found a link between those who have been suffering from malnutrition, and now at the when they become at 20 maybe 30 years, they are developing diabetes. So I think the problem it is how to manage with this starvation that we are looking here in Africa. Most of the recommendation is bringing um, foods that are very rich in carbohydrates. And I think this can be also the cause of what we are observing in this population who have been suffering from this malnutrition. And when they become adult, they develop diabetes. So this is the first thing I have to say about this. But we have also in cities, in towns, we do not have the problem of malnutrition. However, we are looking many obesities because these people, most of them, they've been traveled, they move sometimes in Europe, in USA, and they think that to have a good health, they have to adopt what they saw in Europe and in USA. So they are now, most of them, they are suffering from obesity.
Yeah, and that's, obviously obesity is not a major problem in much of Africa. I think there's parts where it's becoming a problem, but maybe in some of the bigger cities and some of the more developed, wealthier countries, perhaps places like Nigeria and others. Nigeria's got, I think Nigeria is the most populous country in
Yes.
Africa. But what we saw, we're just sort of coming out of this global pandemic, and Africa by and large did not have a high rate of mortality from the COVID virus. And some people would say it's because there's not a lot of obesity there. I mean, we saw every physician that I've ever interviewed said that the majority of people that had problems were struggling with obesity. Is that something that, were you involved in that response at all? And what did you see as far as the pandemic was concerned?
Yes. First, I have just to mention that in some cities like Kinshasa, even Bukavu, you may be sometimes people have to eat foods coming from China, sometimes from Argentina, from USA, here in Bukavu, here in Kinshasa. So although we have also some access to really processed food here in Africa as well. Now about COVID, of course, yes, we did not observe many deaths as it was being expected, and I think, of course, yes, we have the problem of first. We observed in Congo, for example, many cases of death in Kinshasa, in Bukavu, many times in cities because of, I think, the way people have adopted of living. Also, I think also maybe we can imagine in Africa we most of the time we are in contact of many infectious diseases, and I can suppose that we can sometimes have some cross between the COVID antibodies and the other infectious disease that maybe have protected people from Africa. But I do really observe obese people in Africa, and most of those who develop diabetes, they are really obese. Yeah.
You'd mentioned that the guidelines are probably more along the lines of the U.S. guidelines, where it's pushing for a higher carbohydrate diet, probably a lot of grain. Do you find that is there also a belief that meat is bad for you in Africa now?
The international recommendations, yes. In Africa, we most of the time what we are we are using as recommendation there from USA or Europe, and most of the time they are not really adapted for our system. That's why I think we should work more in Africa on trying to bring people to live naturally as they have been as in the past, trying to eat food that are natural and looking at what it's coming in from USA. So we do use their international recommendations that I think are not adapted for our culture, and we should work more on how to adapt the way of treating and of educating people living with diabetes that is really adapted for Africa.
Are you in the Congo? Are you alone as far as your sort of approach to diabetes? Or are there other healthcare providers there that sort of are understanding the role that nutrition has?
Yes, I think I have a colleague who working in Kinshasa. Sometimes we used to discuss about this, but most of the time it is really difficult to make people understand the importance of working more on nutrition. I think this is because most of what we are doing as research, we are getting found from international organizations, sometimes from pharmaceutical firms. So most of them, they are looking more on what we can give as a recommendation, which will giving medicine. But I think, and talking about remission of diabetes, we do not have many funding to 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 conduct studies. So most of colleagues work more on where they can really find easily funding than in a way where it's very complicated to get fund to conduct studies.
Outside of diabetes, which obviously a lot of people have noticed the link between diet and its outcome, what other endocrinological disorders do you deal with that you think nutrition has a role in? I mean, hypothyroidism. You see, sex hormone problems. What kind of things do you see that seem to impact the endocrine system with diet?
Yes, I think that when people are used to eat food that's rich in carbohydrates, this lead to a high secretion of insulin. And with this, I think insulin is an anabolism hormone we use to look with high insulin in the blood. We can observe an accumulation of fatty also in the liver and in the belly, and we have the fatty liver disease. This have a link with insulin resistance, and this is a cycle vicious which leads to diabetes and many other metabolic issues.
Are you? I mean, what are the main medications that are used in the Congo for diabetes? I mean, I assume maybe metformin and insulin, obviously, for the type 1s, but because in the United States we've got all these very expensive injectable medications. I don't know how affordable it is where you are, but I mean, what is the mainstay of medications, and are you able to get people off medications with diet?
Yes, we do have metformin, of course. Also, sulfonylurea like downhill. Sometimes we can find vitagliptin and insulin, of course. So the great issue with this, it is getting, as we do not have insurance that supports everything for people suffering from diabetes, so they have to pay themselves everything. So sometimes these people are not able even to pay medicine. So they have sometimes to stop medicine because they cannot be able to pay this. And this is, I think, a real opportunity for Africa if we can be able to have remission of the disease. This can be a good opportunity for these people who are not able to pay even medicine to control the diabetes. And last time I was counting the medicine they have to do to have most of them, they are diabetes, they have hypertension, they have many other diseases, and sometimes they have to take even 10 medicine per day. And this is very, very, very high for them to achieve. It can maybe cost for one month, $200 or $300 just for medicine. And as you may know, in Congo, most of people to have $1 per day is very complicated. So if we can work on the remission, this can be really a good thing for these people.
Yeah, you mentioned, of the medicines you mentioned, sulfonylureas, which are, in both metformin, those are some of the older medications. In the U.S. now they're using SGLT2 inhibitors and a number of other GLP-1 agonists, which are very expensive. But the insulin, particularly, and the sulfonylureas, when you put people on low-carb diets, those can be problematic. They can precipitate pretty significant hypoglycemia. And so how are you managing those patients? Are you cutting their doses in half, or how does that work when you're taking somebody to a low-carb diet?
Yes, I have an example of a patient who developed a type 2, not a secondary diabetes from, she has been taking for many years steroids for an autoimmune disease. So she developed a diabetes, and she started treating this with insulin. She had been receiving per day around 60 units of insulin. And then we start working on diet. Now she stopped everything. She do not really receive any more insulin. So when I start this, I have to stop some medicine and sulfonylurea, for example, and also insulin. I have to really reduce the dose of that she have to receive, and have to follow him every week to try to reduce every time the dose of insulin.
What is the, as far as, I'm just wondering what practice is like. Do you have time, in the United States, a lot of endocrinologists or primary care physicians that would treat diabetes have very limited time with their patients. It's very high volume. Are you able to spend time and help people with lifestyle, or how does the practice work in Congo?
Yes, of course, it's very complicated to have the time to discuss with a patient as every time you see for 30 minutes for the consultation. So I started a company. I'm giving some course for diabetes every weeks for six weeks of course every day, 1 hour per weeks, and used to use Zoom to discuss with them about that. So for the first week, I discussed with them about the disease diabetes, and then I introduce the low carb for them. And this take 6 weeks, and then they can come to the consultation with what I have been telling to them about the how to reduce this. In the consultation, not easy to have this time, so I'm using this 1 hour per month at the weekend for those who want to join the course.
I'm trying to. I was just going to look at some things on Congo. So you're the largest French-speaking nation in the world.
Yes.
You got tremendous reserves and diamonds and other natural resources in there. What has been going on in the Congo in the last 50, 20, 30 years? Are you getting more and more developed? Are you utilizing some of the wealth to modernize the country, or what's happening in the Congo these days?
So, Congo, as you said, is the big speaking French country. We do also speak Swahili. In the Eastern Party, we do speak Swahili. So I do speak Swahili, and then when I'm in Nairobi, in Tanzania, it's okay for me. And the West Party speak Lingala. Now we are challenging in the Eastern Party with some security. We have many army groups that are trying to fighting between some ethnic groups. Sometimes so this is the big challenge for us to the big challenge here in Eastern part of Congo. It is sometimes the insecurity. Now we are preparing the new election next year. So, and hope that everything will be okay, and then I will be able to continue working and trying to teach people about this low-carb. And I hope in the future, I'm expecting to have many of my colleagues working in this field and trying to more work on education people about the nutrition than giving medicine.
Yeah, so I think when I was in Tanzania, which is next door to the Congo, I remember, I think Swahili, you learn some of the animal names, Simba, and I can remember elephant was Tembo and things like that. And I know we used Poa was to go slow when you climb Mount Kilimanjaro. I remember a few Swahili words, but
yes.
So, and I guess, is there still quite a bit of political instability or fighting in the Congo? Does it make it hard to practice there?
So sorry.
Is there still quite a bit of instability going on? I mean, I know there's been some wars and problems. Is that still happening?
Yes. I will speaking about what I'm doing here in Bukavu. Most people living in Bukavu, we are more collaborating with the eastern part of Africa, so Kenya, Tanzania, and most of what we are doing, we learn, trying to give some change with our colleague from the East African, and I'm happy because last month Congo has become a member of the East African community. And I hope that this will bring more security in the eastern part of the Congo, and then we can imagine many things and try to move more working with other colleagues in other cities, other area in eastern part, and try to giving the what I consider as the good information about trying to work with diabetes.
Yeah, it's interesting. I was in Dubai last week, and I was chatting with a couple folks that were there. One was from the South Sudan. He was part of the Dinka tribe, very, very tall, some of the tallest people in the world. And they, and Sudan it has a border with, or South Sudan has a border with Congo. I see it up in the north there. And I just wonder, do you have any sort of different dietary patterns in certain parts? Do you have any of the folks that are kind of like, we hear about the Maasai, living in Kenya and parts of Tanzania, where they're pastoralists and they eat meat-based diets. Do you have a population similar to that in the Congo?
Yes. Here in the east of Congo, we do have some population that have, for many years, have been working as a pastor. I think many population on the border, eastern border of the Congo, they used to in their diet they used to take milk, and I remember sometimes they were also taking blood from. So it is. I think it's the same as what now people of Masai used to do. This is, I think, in the past, eastern part of Congo used to have as diet. Now things have changed because of the mix of population. We have population from Lubumbashi, and they bring their way of their culture as well. So, but we do have big population here in Bukavu. And for example, Bukavu, it is in the local language means coal. So it is exactly the same population.
And is there a difference in, say, population health between these folks? That, like a lot of times they'll point to, differences in height, for instance. We see these Nilotic populations where they're very tall, where there's other ones that are sort of more plant-based that tend to be much smaller. Do you see a difference in the different sort of regions?
Yes. I think people living here in Bukavu, in Goma, they can have the same way of eating, but when we move more in the West party, this thing are changing. So people from Bukavu and Goma, they are eating as people from Tanzania, from Kenya, and also people from Kinshasa, they are eating as people from Libreville, from Cameroon, and so more we move to west of Congo, more we can observe some modification in the way of, even in the culture, we have some different.
Is there a difference in health? Is there a difference in overall health between the eastern folks in Congo and the western half? You said the eastern folks are more like Tanzania, Kenya, and then perhaps you've got more Gabon and Cameroon on the western side. Is there a difference in their health, diabetes rates, or anything like that?
No. For diabetes, I think the last studies that we conduct, I saw here in Bukavu, in Goma, and Kinshasa, we have the similar prevalence and also the similar characteristics of the population. They are most of them obese. They have adapted a new way of eating, a new way of living, trying to adapt the way of living as what they saw in Europe. So I think it's the same thing in Bukavu and in the Western party, and I think it's linked to the westernization of way of living. Yeah.
Do you find that there is, when you look at life expectancy stats, Africa often has some of the lowest life expectancies in the world, often 45, 48 years of age. Is that mostly due to things like infant mortality or infectious disease? Or are you getting people that are living older into their 70s, 80s, and 90s if they avoid the sort of infectious disease and childhood problems?
Yes, I think we have, of course, the infectious disease that the first, we have malaria, we have tuberculosis, but now we are observing also some problems like stroke, we have diabetes and hypertension. They become more and more, I think in the future, they will be the first killer in Africa as well. And also, if I consider the HIV, we do have a control of this. So people are living more than we could expect in the past. And they are developing with the medicine and also with the disease. They are developing as well diabetes, heart attack. So people living with, for example, HIV, they are dying more now with diabetes, kidney diseases and heart attack than just infectious opportunity infections. So I think in the future, diabetes, hypertension will be the most killer in Africa as well.
That's unfortunate that we're exporting our diseases, around the world, and
Yeah.
Africa is no difference. Do you, how, in the United States, the dietary guidelines are pretty widely held. There's a lot of, federal funding to a lot of like schools, and federal agencies depend upon that. Is there something similar in the Congo, or most people have to eat whatever they kind of want to eat?
Yeah. So what I said, for people living in Africa, be having a good food, it is try to respect what is recommended, the international recommendation coming from USA and Europe. That's why talking about recommendation, we do not have national or African adapted recommendation. We use the one coming from USA and Europe. So people who have money, they are trying to respect what is it's recommended by USA and Europe, and they are getting sick, of course.
Yeah, I mean, I don't know that USA would be anyone's ideal model on our food guidelines, given the health results we have with regard to chronic disease. Do you, when you let's talk about your Zoom situation, because you said you don't have time to spend an hour with every patient in the clinic. How is that working for you? I mean, obviously we're talking on Zoom and we rely on this. We have a large community of people that we support, and how does that make a difference for you?
So first, the limitation of what I'm trying to do it is that everyone uh, of those who I'm following as patient do not have access to internet. It is very complicated for them. So this is do not have another way to do this. So those who can attend the meeting is those who are able to have internet, to have a computer, and to be able to use Zoom. So most of them, they are educated people. What we do, I'm preparing some slides that I share with them 2 days before the course. They can read them, and then we start reading them together and trying to have some discussion about what I'm suggesting. And sometimes we discuss about what is the international recommendation. We discuss about this and try to adapt and to correct the way of eating in Africa of what we do have here in Bukavu.
What do you think is driving the diabetes and the increase in diabetes and then subsequently heart disease and hypertension in Africa currently? What dietary change have you seen? Is it more sugar in the diet? Is it more processed food? Is it more vegetable oils? What are you finding to be the problem? What do you think might be the problem?
I think the big problem is more sugar and processed foods. I think this is the what I can see in big cities in Congo. It is because people are trying more to get their food in the supermarket than trying to go at what they had been done before. And I think this is the big issue. And, trying to explain to this population that this is not good, it's complicated because uh, going and get shopping to a supermarket, it is like a way, it is considered as in the city with different colleagues as a way of I've succeed in my life as I'm able now to go and to get some food from supermarket. That's why when some people get money, they are trying to go in supermarket, taking processed food, and I think this is for me the really underlying causes of diabetes in Africa.
Yeah, that's and it's kind of funny. Everyone here is trying to go the opposite way. They're trying to spend less time in the grocery store and eat, sort of very simple foods, which and you see the opposite happening in Africa. Do you, it's kind of interesting because if we could roll back the clock 50 years in the United States, we would probably be, maybe kind of in a similar situation where you might be. And us now would say, no, don't do it. don't proceed down the path of all the ultra processed food. Do you see many people that can look at the United States and other developed countries and see all the obesity and diabetes and see the problems with nutrition that might be saying, hey, this isn't the right thing to do? even within the government, or is it just too lucrative to just kind of invite these corporations in to provide all the processed food?
Yes, I think as we are starting, now we have 5% of diabetes, so this is not the start, but I think we are looking at increase of the disease, and we have the opportunity now to stop this. And if we try to work more on the prevention, changing, bring people to understand that processed food is not good for them, and cutting sugar in what they used to eat, and try to eat as they have been done maybe 20 years ago. This is very we have this possibility. We can make a big change for all this population. But I think we have to include the government and many others organizations. And unfortunately, they are not working more on this. They are trying to work more on bringing medication for people suffering from diabetes without looking on why we do have many cases of diabetes in Africa.
Yeah, that's unfortunate. They just want to make sure you have access to more medication instead of just fixing the problem. Congo is 90 million people roughly. It's a very large nation, relatively. I mean, U.S. is 340 million or something like that, but you're still quite a large nation. Is there do you have like a health minister or someone in charge of we have the equivalent, it's a surgeon general? Do you have somebody that is talking about from the government, talking about eating well and exercising and that type of stuff?
Unfortunately, no. We do have the health ministry, but most of what they used to do, it is working more on infectious diseases like HIV, tuberculosis, and malaria. And also, most of the time, our Ministry of Health is working with WHO and many others organizations that have other priorities for Africa. For them, Africa, it is where we found diabetes, not diabetes, but HIV, hepatitis, malaria. So they are bringing money for just this and prevention of HIV, malaria. We do have many information about this, but nothing about diabetes, hypertension, how to prevent this. We do not have anything about this. And when we look on, we do have also a national diabetes program, but when we discuss with the director of this program, nothing is coming from the government to help him try to implement a prevention program. So this is the big issue for this.
Well, and certainly Africa had a lot of issues with HIV, a lot of deaths were attributed to that. And of course, obviously tuberculosis, malaria, those are big killers. Is that coming under control? I mean, has that reduced significantly? Like how many people die a year in the Congo of those diseases? And is that number going down significantly?
So now I do not have the exact number of people dying from this, but I cannot say that what people have been done for diabetes, for HIV, tuberculosis, and malaria bring a control of this disease. No, because I'm still seeing many cases of tuberculosis, of malaria, although many activity have been done for this, and many organizations have given too much money for this, but I'm still seeing many cases of tuberculosis and malaria.
Do you think that diet and lifestyle affect the outcomes for those diseases, these infectious diseases, whether it's HIV, malaria, tuberculosis? Just like we saw with COVID, infectious diseases tend to be worse in the people with these metabolic, comorbidities like obesity and diabetes. Do you see any difference with the population with regard to those other ones? It might make a difference.
Yes. If I consider tuberculosis and COVID as well, we saw a link between this and diabetes. People suffering from diabetes, they are getting easy tuberculosis and COVID. Also, people suffering from diabetes, they can develop very quickly liver disease if they have the hepatitis B or C infection. So I think if we work more on lifestyle, as you said, we can even prevent some diseases like tuberculosis and, of course, coronavirus as well. Yeah.
Do you spend time out of Congo much, or are you in other parts of Africa, other parts of the world? And if so, who do you? I mean, where are you patterning some of your? You said you mentioned. I can't remember if you mentioned other doctors that you learned about low carbohydrate diets.
Yes. Sometimes when start my practice, I can go to Belgium, Nairobi as well. But I've never been in UK. The one Dr. Kavan with whom we started with this talking about low carb, it's just on Zoom we start talking. So as I said, I read his book and then I contact him and we start collaborating. He share with me some materials from his organization that sometimes I'm using when I'm teaching people. Of course, I adapted this because food from UK and from here is totally different. So I have to adapt this from Africa, but he shared with me the basic of what I'm using to teach people. Yeah.
What does your personal diet look like? What kind of foods do you typically eat? I know when I visited Tanzania, I know it was rice and some sort of meat were very common meals. Is that similar to what you eat, or how do you eat?
Yes, the same. It is rice and some banana, some yam that we used to eat here in Bukavu. What I'm suggesting now, it is, people in the past, they told them that if they are getting diabetes, they have to eat 3 times a day, morning at two times a day, and I think this it was because they have been receiving sweet from urinary, and to avoid hypoglycemia, they have to eat 3 times a day. But now I'm talking to them that we have not to eat 3 times a day. We can eat two times a day in the morning and night, and take medicine that cannot bring you to hypoglycemia. And sometimes you can avoid rice and just take meat and vegetables. And we don't need every time to eat rice in the food. And they are trying, they can make some economy of the medicine they have to take every time. And as well, also, to be obliged to eat 3 times a day is very complicated. When they have to go to job, they have to stop working, come back home to eat, and then this is very complicated. They are trying to eat 2 times a day, and it's working.
What sort of, when it comes to different sources of protein, what sort of meats are used? Is it a lot of chicken? I know chicken was popular in Tanzania. Do you have much in the way of beef? Do you have other game animals? What sort of foods are typically there from a protein standpoint?
Yeah, we do have chicken, beef, and pigs. Pigs, we do have also pigs here. And sometimes for those who can have eggs, they can also take pigs. And also we have some vegetables like beans that can bring some protein. Yeah.
Do you have much of a presence of people that want to do plant-based or vegan or vegetarian diets? Is that very common there?
No, we do not have people who, but I know that what they receive sometimes as a recommendation is when you develop diabetes, you have to avoid meat. But now I think they understand that this is not true. You can eat meat and really control your diabetes without any problem.
Yeah, that's what. And in case you don't know, this whole community is a group of people that eat primarily meat. Most of their food is either entirely meat or mostly meat, and they do very well with that. And we've seen some of the best control in diabetes, whether it's type 1 or type 2, which I think is very important to realize that. We are closing in on time. I've got just a couple minutes, so if you would, I know if you can maybe share where people might want to go to find out more information about what you're doing in the Congo, maybe find some more about you. Where could they go?
So just to say thank you for having me here, and I think this is for me an opportunity to let people from outside, from other countries, that we are trying to work more on prevention than trying to treat the disease. And I hope that in the future we can be able to teach other colleagues about this, and they can start working in this way. This is my dream in the future, to have many people working on prevention more, taking time to explain the good way of eating, than just receiving passion and give medicine, because this way of working doesn't work. Yeah, I think this is, yeah.
Yeah, I agree completely, and thank you. And like I said, as we expand with our company, and we'll hopefully have a global presence, and hopefully maybe we can one day get out to the Congo and help support you in your mission. And I'd love to visit someday, maybe down the road. Anyway, thank you so much for being here.
Thank you.
Have a great.
You
keep up the good work.
You are welcome in Congo.
Okay, thank you. Appreciate it.
Yeah, just tell me, and I'll manage to invite you and welcome you in Congo.
That would be wonderful. Thank you. Okay, guys.
Thank you.
Thanks everybody for being here. We'll see everybody tomorrow. Thank you. Bye-bye.
Thank you. Bye-bye.